Assalamualaikum and good evening. Welcome you all to our weekly virtual session on gynecological malignancy. Today our discussion is the patient's stories. How can we help our patients by guideline practice? It is the regular continuous medical education series of the Oncology Club, which each week we are arranging the program for around, it is around last September we first started that. It is more than 1 year. And today is our the program is at first we have to discuss one case, and accordingly we have give the poll questions at first, and poll questions it will be, we shall give the poll questions and all participants are requested to answer the poll questions. After that we shall ask the local faculty about the questions, and then the foreign faculties. After that we shall tell what is the guidelines. And we selected two cases today. One is the epithelial ovarian cancer and another is the germ cell tumor. Our faculties today are, we have two local faculties. One is Dr. Farhana Kalam. She is the gynae oncology. She passed a fellowship in gynae oncology this year, and also she is fellow in obstetric and gynecology and working in National Institute of Cancer Research and Hospital. Another fellow is Dr. Sabrina Kadir. She also passed a fellowship in gynae oncology and fellowship in obs and gynae and working in National Institute of Cancer Research and Hospital. And our foreign faculty students are the Dr. Abraham Pedicel sir. Sir is senior consultant in gynae oncology, Sultan Qaboos Comprehensive Cancer Center, Master. Another one is Dr. Monish Sharma. He is the consultant and head of the unit Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Professor Amita Maheshwari, she is a known face and to all, and she is professor and head Department of Gynae Oncology, and also she is the president of the Association elect of Association of Gynecological Oncologists of the India. And another one is our Dr. Annie Catherine Goodman. She is also gynae oncologist, professor of obstetrics, gynae, reproductive gynecology and reproductive biology, Harvard Medical School, Boston. Today we have with us the scientific secretary, Dr. F.M. Kamaluddin, our inspirator, Professor M. Shulful Alam Sir, who is the general secretary of the Oncology Club, and who is the man who is always with us from very beginning to end, Professor Dr. E.M.A. Haisen. He is the president of the Oncology Club. And according to our custom, I would like to request our president of the sessions to tell something about the today's program and give us permission for starting the session. Sir, please.
Thank you, Dr. Sahana. It's a great pleasure for me to welcome you all. We have today our faculties from Oman, Dr. Abraham Pedicel, from India, Monish Sharma and Amita Maheshwari, and from USA, Annie Catherine Goodman. Our local faculty are Sabrina Kadir and Farhana Kalam. The discussion is how can we help our patients? Sometimes all the time we cannot follow the guideline. How best we can follow the guideline, that will be our discussion. Without delay, I think we should start. Start over to you.
Thank you, sir. Thank you very much. My first case is Mrs. X. Mrs. X, a 16 years unmarried girl. She presented with fever and lower abdominal pain and distension, abdominal distension for 1 month on a private clinic in February 2021. And there a local doctor advised the ultrasonography of the whole abdomen on that time. And ultrasonography report showed a large hypoechoic masses, which is about 14.7 into 9.9 centimeter and attached in the posterior of the uterus, mostly on the right side. With this report, she underwent laparotomy followed by the right-sided sulfine oophorectomy on 18th March 2021. Now, this is the first poll question to all the participants. All the participants are requested for poll voting. You please answer. It may be either wrong, or it may be partially right, or it may be fully right. So please, all of you are requested for poll voting. What are the other imaging methods for diagnosis of the ovarian cancer? Whether we shall go for the ultrasonography of the whole abdomen, CT scan of the whole abdomen with contrast, MRI of the pelvis and abdomen, or PET scan. In such type of lady with 16 years girl with a 14 into 19 centimeter adnexal mass. So 49% participants were voted. Among them, the 15% is in favor of the ultrasonography of the whole abdomen, 39% CT scan of the whole abdomen with contrast. Abraham sir join করছে তানিয়া আব্রাহাম স্যার জয়েন করছে, অমিতা ম্যাডাম
কোহোস্ট করে দিয়েছি।
অমিতা ম্যাম
এখনো জয়েন করেন নাই।
দেখেন তো আইফোন ফোন দিয়ে মনে ম্যাডাম জয়েন করেন। iPhone.
Sorry, Dr. Sahana, I joined late. I got the time wrong. Sorry.
Oh, sorry, sir. No problem, sir. iPhone, দেখেন তো আইফোন দিয়ে মনে হয় পোস্ট করে দেন। And 40% are in favor of the CT scan of the whole abdomen with contrast, 40% in favor of the MRI of the pelvis and the abdomen, and 3% only in favor of the PET scan. Tanya, stop the poll. Stop it. Yeah. Close the poll question. Tanya, please. Tanya? Tanya? তানিয়া, আপনি কি পোল কোশ্চেন ক্লোজ করেছেন? আমার এখানে ক্লোজ হচ্ছে না কেন? তানিয়া,
ক্লোজ করেছি ম্যাম।
ক্লোজ হয় নাই তো?
ক্লোজ হয় নাই তো।
আচ্ছা,
ক্লোজ করো দেখ। অমিতা জয়েন করছে। আবার আসলো কেন এখানে? ওইটা ক্লোজ করো, তার সাথে ওই স্লাইডটা চেঞ্জ করো।
ম্যাম ক্লোজ কি হয়েছে? এখানে এন্ড পোল দিচ্ছি কিন্তু তারপর শেয়ার রেজাল্ট চলে আসছে।
শাহানা, তুমি স্লাইডটা বন্ধ করে আবার অন করো, এটা প্রবলেম।
আচ্ছা,
শাহানা স্লাইডটা অফ করে আবার অন করো তাহলে।
আচ্ছা,
স্টপ শেয়ারিং বন্ধ করতে তো
আবার অন করো, বা সবার সমস্যা।
এখন কি ক্লোজ হয়েছে?
এখন ক্লোজ হয়েছে। Okay. Now my first question is Dr. Sabrina Kadir. What is your opinion? If you get this type of the patients in a center where you are working between 16 years lady with a 16 into 9 centimeter mass with abdominal distension pain and ultrasonography with having a ultrasonography, what other investigation do you like to do for these patients? What is your opinion?
Assalamu alaikum, madam, and assalamu alaikum to everyone. With this scenario, I would like to perform MRI of whole abdomen.
Why?
as ultrasonogram has done and it gives inconclusive result. So I will do MRI. MRI will give a clear scenario of the adnexal mass. It can also give me some features of malignancy if it is distant metastasis.
If you are working in a center where there is MRI facilities or other advanced imaging facilities is not available, in that center, what will be your further thinking, or what will you do next? Like a simple ultrasonography.
In a center,
in that cases.
In a center, if I don't have the opportunity for CT scan or MRI, then I will advise for ultrasonogram of whole abdomen with an expert hand, because ultrasonogram with expert hand can seeing some characteristics of the mass can differ between benign and malignant tumor.
My question is to the Abraham sir. If this type of the patients it attend in cases where there is only the district hospital or in the Upatala level hospital where no facilities available, only the ultrasound available, in that cases, how will you take the decision for getting the next treatment plan? Sir, please. Abraham sir. You are muted, sir. Abraham sir ke host karen nai. Tania.
করা আছে ম্যাম, উনি co-host.
Dr. Abraham is co-host.
Co-host.
Sir, muted.
Amita is also co-host.
Sorry, I was muted. Okay, sorry.
Sorry,
Yeah, I
sir.
missed the. Sorry, Dr. Sana. I've unmuted myself. I was just saying that sorry I came late. I missed the first part of the presentation. Yes, if no advanced imaging modalities are not available, then we'll have to make do with what we have. An ultrasound with Doppler can be done, and then if there's evidence of advanced case of malignancy, then probably this patient will have to be referred to a specialist center. At least we can, looking at the full clinical picture with the tumor markers, with the ultrasound Doppler, you will get a fairly good idea as to whether this is malignant or not.
But sometimes in our patients, as you know, in India, Bangladesh, in that area, the more than 80% patients are the poor and they cannot afford the to go the higher centers. So in that cases, and you will have to take the decision. In that cases, how can you take the decision? By only ultrasonography? And we can have to take the decision by doing ultrasonography. In that cases, how can we differentiate it, whether it is benign or malignant, sir?
Yeah, there are different ways of doing it. I mean, you look at the ultrasound features, the aorta, you can make out whether the benign features and the malignant features, and then you try and decide. I mean, there are scoring systems. You look at the septal thickness, you look at whether there are solid areas, you look at whether there are excrescences, you see whether there's anything on the surface of the tumor, look at the blood flow, you look at whether there's ascites or not. So putting all these features together, there are different systems to try and help you formulate your opinion.
Thank you, sir. So if any patients like this is we attend in our peripheral centers like Upazila level or in centers where there is advanced imaging is not available, only simple ultrasonography is not enough for decision making. Sir, Dr. Abraham sir, his opinion is we shall go for the either color Doppler or the expert hand, because in that cases we can differentiate whether it is young lady, whether it is benign or malignant. Accordingly, we shall take the decision. And also, this is the IOTA group. This is which was the international, the ovarian tumor analysis group, where the rules based on the clinical and data from the 1,066 women in a renowned centers in 5 countries, where the 9 centers were included here. And their opinion is that where there is the benign fissures and the malignant fissures. The benign fissures using a mass is classified as benign. If at least B fissures is present and no one malignant fissures, that is, what are the benign fissures? The benign features is the unilocular cyst, present of solid component with less than 7 millimeter and presence of the acoustic shadow and smooth the multilocular tumor and no blood flow within it. This is the benign feature. And in malignant feature, using iota rules, the mass is classified as malignant. If at least one M feature is present and no benign features are present, then we shall take it the malignant. The rule on if one or more M features are present in the absence of B features, the mass is classified malignant. And rule 2, if one or more B features are present in the absence of M feature, the mass is classified as the benign. And last, this paper, this was published in the February 2021, the European Society of Gynae-Oncology, European Society of International Society of Ultrasonography of Obstetrics and Gynecology, International Ovarian Tumor Analysis Group, and the ESGE, the consensus statements that preoperative the diagnosis of the ovarian tumor. And there, they commented that by the iota system we can do this, whether it is benign or it can be a malignant mass. Then our next question is that question she has undergone a laparotomy followed by the right sided salpingo-oophorectomy, and part of the tissue was sent for the histopathology report. And the histopathology report showing there is the malignant germ cell tumor compatible with yolk sac tumor and external aspect is involved by the tumor. Sorry. Now my question is, Dr. Sabrina Kadir, whether are you satisfied with this small amount of this tissue which was sent for the histopathological report, and what is its significance for the reporting of this patient? What is your opinion?
According to me, a part of tissue for histopathological examination should not be sent. Instead, it should be sent in total. And the identifying if the ovarian mass is associated with fallopian tube, everything should be, or uterus, everything should be sent for histopathology. And in histopathology, the mass should be described, its gross feature like size, like capsular involvement, and also LVSI component. It all should be described by a histopathologist.
Yes, that is the rightly said. The European Society of the Pathology, that is gynec pathology, they are working up, and the gross description must be written in the histopathology report. That is integrity of the specimen, whether it was intact or fragmented, ovarian capsule intact or the ruptured, the size of the tumor in 3 dimension, description of the color and consistency, and microscopic feature also included the presence of the capsular involvement or the breaching of the capsule, histopathological type according to WHO classification and histological grade, presence of the borderline component, extent of the local tumor spread, and also the microscopic evidence of the LVSI, because according to it, the next treatment plan of the patient depends. So that next 4 questions. This is a lady that is years with a 14 into 9 centimeter adnexal mass, underwent a unilateral salpingo-oophorectomy, and her histopathology report yolk sac tumor with surface involvement. Now, the second 4 question to all the participants: what is the next treatment plan if these patients come to you? Will you go for observation with these patients as she is young, or will you go for the resurgery, that is malignant, or will you give the adjuvant chemotherapy? Tania, এটা আপনি কি কোশ্চেন দিছেন কিসের মধ্যে? তানিয়া, 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 এটা ক্লোজ করেন।
আমাকে ক্লোজ করতে হবে, ওইভাবে ক্লোজ করতে হবে, এটা মানে ক্লোজ হয় না।
আপনাকে ক্লোজ করতে হবে।
আমি তো ক্লোজ করব। আমি কি পুরো স্টপ শেয়ার স্ক্রিন স্টপ করব?
এখন আবার অন করা ঠিক হয়ে যাবে, এটা নাইলে যায় না।
আজকে এত গন্ডগোল হচ্ছে কেন?
তার পোল কোশ্চেনটা কোনো ডিস্টার্ব করে স্যার, আমাদের সেশনও হয় স্যার, এটা আমরা নিজের অফ করে অন করি স্যার।
একবার হচ্ছে তো সেজন্য বলছি।
এখন পোল কোশ্চেনটা দেন তানিয়া।
প্রিভিয়াস স্লাইডে যাও।
Yes. Yeah. Have to return back to Tuesday because there is various program in Sunday. Participants, the number of participants are decreasing. 27% participated in this. Among this, 5% is in favor of the observation, 24% in favor of resurgery, and 71% are in favor of the adjuvant chemotherapy. আমার post করতে হবে। সেদিন তো এরকম আর হয় নাই। This patient, she received 6-cycle adjuvant chemotherapy with etoposide and cisplatin up to 12 August 2021 with etoposide and the cisplatin. And was this schedule appropriate for her only EP 6-cycle? Dr. Monish sir, please. Monish sir, please. This patient.
Good evening. Thank you so much for inviting me here, and it's a pleasure being here. So I am here for the first time. I was listening to the cases very well. Like in testicular tumors, we prefer using BEP in ovarian cancers as well. But stage 1A, grade 1 immature teratomas, and stage 1A, 1B disorders. Except for these two stages and grades, we don't administer. We administer chemotherapy to all the people. Number one. Number two, classification of high risk and low risk is extremely clear in testicular cancers. Unfortunately, there is no consensus definition for prognostic risk group in ovarian cancer, right? So we usually classify testicular tumors into high risk, intermediate risk, low risk. But in ovarian cancer, there is no such consensus guidelines. But one simple categorization is to categorize stage 1A as a good risk, 1C to 3 as an intermediate risk, and stage 4 as a poor risk, right? So we prefer giving at least 3 cycles of BEP to all the people, at least for the good risk and intermediate risk. But if the patients they are poor risk, we try to give 4 complete cycles of BEP. If pulmonary toxicity is an issue and is contraindicated, we don't use bleomycin, and then in that case we can use 6 etoposide and cisplatin, right? So since I think this was a stage, what stage I could not see. It was stage 1. Stage 1C, right? So it as per me falls into the intermediate risk category, and 3 cycles of BEP would have been sufficient for me for this patient.
My question, usually in other tumor, we give 6-cycle chemotherapy. Why 4-cycle chemotherapy, 3-cycle or maximum 4-cycle in germ cell tumor?
So germ cell tumors, they respond extremely well to the chemotherapies, and most of the patients, they will get their treatment completed by 4 cycles of chemotherapy. And further treatment is unnecessary for these kind of patients, except for those patients who don't their tumor markers down to the normal, don't administer further chemotherapies. For those patients get their tumor markers to the normal range by 4 cycles of chemotherapy, they are considered to be chemo-refractory disease. And these patients, they have to be on line of treatment rather than continuing with the same BEP for 2 more cycles or EP for 2 more cycles. So most of the patients, they will complete their treatment. They will normalization of tumor markers within 4 cycles. If patients, they are not normalizing their tumor markers by 4 cycles, that means it's a chemo refractory disease. And now these patients have to go on to the second line of the treatment, which in most of the cases is TIP, paclitaxel, ifosfamide, and platinum-based chemotherapy.
AK, Dr. AK? AK?
Yes, I completely agree with all the comments. And I was thinking, I wasn't sure I heard if she'd had tumor markers done with a yolk sac tumor, whether there were any tumor markers associated with tracking how she was doing. So that would be my question clinically. But I agree, the NCCN guidelines are pretty clear in terms of malignant germ cell tumors for standard risk, which she would be in at a stage 1C to give 3 cycles of BEP. I mean, it's sort of not wrong to give 6 cycles of EP. I'm glad that there was no bleomycin given for 6 cycles. We talked about that at a previous meeting together about the toxicity of bleomycin causing pulmonary fibrosis, and that can be a fatal complication. Once you have pulmonary fibrosis, you're not going to ever fix that. So have someone who's potentially disabled. But yeah, very good conversation.
Okay, thank you. Then what is the NCCN guideline in version 2021? That is the treatment of the germ cell tumor. The chemotherapy regime is the BEP. Either it is 3 cycle. If it is more than 1 cycle, we can use only the EP. And it is also the NCCN recommendation. The patients, after 7 months of the initial surgery, the patient has undergone surgery in March 2021 and received chemotherapy and completed on August 2021. She presented in outpatient department of National Institute of Cancer Research and Hospital in 5th October 2021 with heaviness of the lower abdomen, feeling of a mass, again mass in the lower abdomen, and on examination, a mobile mass was felt about 8 into 6 centimeter in the lower abdomen below the umbilicus. And having a ultrasonography, they report the one mixed echogenic outline, the mass is around 6 into 4 centimeter in one adnexon, another solid mass 3.9 centimeter in the pelvic region with mild ascites. And then we have advised that the CT scan of the abdomen, the CT scan whole abdomen is showing the uterus. This is the uterus is normal in size, but the multiple complex mass in the pelvic cavity, largest one into 6 into 4 centimeter. In the right side, a complex midline mass 5 into 4.2 centimeter at level lumbar 4-5 level, but there is no ascites, no abdominal or pelvic lymphadenopathy. Her tumor marker, the serum alpha fetoprotein was 1076 nanogram per ml, LDS was 342 unit per liter, and the beta acids were 6.8 milli-international unit per ml. She's 16 years, unmarried, with history of right-sided salpingo-oophorectomy with adjuvant chemotherapy. Now, another complex adnexal mass and solid mass on ultrasonography and also in the CT scan. Now, this is the 4 questions. What will be her next treatment plan with this 16 years lady? Tanya, 4 question, please. Whether we shall go for the chemotherapy, again, we shall give chemotherapy to these patients, or we shall go for the definitive surgery, or we shall go again for the fertility sparing surgery. 19% are in favor of the chemotherapy, and this 48% are the definitive surgery, and the 31% again are in the fertility sparing surgery. Now we have to stop the poll question. বন্ধ করেন তানিয়া।
বন্ধ হয়েছে ম্যাম?
হ্যাঁ আবার ছিল। Now, Dr. Sabrina, what will you do with these patients? What is your opinion?
Madam, I would like to do definitive surgery.
Why?
Because her previous surgery was right salpingo-oophorectomy and now mass in left side, and she has received 6 cycles of chemotherapy with no response, so early recurrence. So definitive surgery may be her treatment of choice.
Amita madam. Amita Maheshwari madam.
Yeah, hi, good evening. So, yes, surgery with consent for definitive surgery, but I think the final call will be intraoperative. We need to see where these tumors are now, whatever we are seeing those masses. And even if we have to remove other adnexa, if there is disease in the other ovary, we can still conserve her. And this time we should send the entire specimen because yolk sac tumor recurrence is very unusual to have this kind of picture recurrence on the opposite side within few months of first surgery. It's very unusual thing, although her AFP is elevated, so that is in favor of recurrence of yolk sac, but we also have to look for if there is any other component, if there's a dysgerminoma or teratoma or something else in this patient. So definitely the entire specimen should go for histopath, and she will require additional chemotherapy. Second line, what was mentioned, either TIP or VEIP, one of those.
Thank you, madam. Yes, this is also NCCN guideline is the same. That is, this is the recurrent tumor. There is the abnormal the tumor marker, and also in the imaging. Then we shall consider the surgery in the sub, and also followed by the consider the additional chemotherapy. And what is the option of fertility? As we know, this is the yolk sac tumor, and also in the dysgerminoma, usually it is rare for the recurrence, but even after that, it is the patient recurs within the few months. But if it is the mixed germ histopathology report, it comes the mixed germ cell tumor. In that cases, what will you do? Is there any option of the frozen facilities? Because we have there, after getting the opening the abdomen, we have found the opposite ovary is also involved, and after that we just keeping the small amount of the ovarian tissue and also the uterus keeping behind, we have completed the surgery, and report comes the mixed germ cell tumor. In that cases, what will you do? Madam?
Yeah, so if there is some normal ovarian parenchyma is seen, if intraoperative and tumor is on one side, we can still take a chance. Of course, we need to explain to the patient and family before surgery. Counseling is very important. If normal ovarian parenchyma is seen, we can preserve the normal ovary, provided there is some decent amount of ovary and uterus can be left. Whether it's mixed or one kind of histology, I don't think that will change their plan, because it really doesn't matter whether it's a yolk sac or it's a dysgerminoma or whatever. So provided you are able to see some normal ovarian parenchyma.
If there is no normal,
and the other thing is we also should do AMH level. If one ovary is out, other ovary is grossly diseased, so baseline AMH before surgery is also important, because we'll know normal ovarian reserve in the remaining in this opposite adnexa. And of course, other things like, yeah.
Yeah. And there is also the scope of the fertility sparing surgery in the malignant ovarian germ cell tumor. This journal was published in the 15 years experience. There is no they required the infertility treatment, and 5-year disease-free survival was 87% and 10 years was 94.4%. So we can go for the fertility sparing surgery even after the recurrent germ cell tumor. So now we shall end the cases, but we have I want to show some the updated the guidelines and the message for our colleagues who are there, because there are also the general OBGYN specialists with us with this program. So we want to show some updated guideline on European Society of the Gynae-Oncology. Just a minute. What is their recommendation, the general principles of the management of the germ cell tumor, as because all our colleagues that we invariably, there more than 80% or 85% patients they are treated by the gynae colleague, then, and they are also in the peripheral centers or where there is the oncology facilities are not available. And their recommendation is that in patients with suspected ovarian tumor, preoperative diagnostic workup should include at least abdominal and pelvic ultrasound, MRI of the whole abdomen to decrease the chance of giving the radiation effect, and also the thoracic CT scan and serum tumor marker, that is C1 alpha fetoprotein, beta LDH, and also the abdominal pelvic MRI. Then there is no indication of the PET CT. And in case where the immediate surgery has been performed before this investigation, we must go for those investigations, that is the advanced imaging and also tumor marker. Even surgery has done, we must have to go for this investigation even after surgery. And also in case of the cystic component, puncture of the cyst must be avoided. Oophorectomy should be performed without cystectomy. Biopsy of the tumor are contraindicated except in cases where the extra ovarian spread, and midline laparotomy should be done. That is, the incision should be given in midline, and also the minimal invasive surgery. There is an option for minimal invasive surgery. What is that? That is, if surgeon is well trained and she can remove the tumor without rupture, without morcellation, and she must have to go the full exploration of the peritoneal cavity, and also the staging of the tumor should be included. That is, collection of the peritoneal fluid or the peritoneal washing, examination of the peritoneal surfaces, biopsy of the diaphragmatic peritoneum and other peritoneum surfaces, pelvic and parietic lymph node excision. Only removal should not be done. Only excision of the enlarged lymph node, inspection and palpation of the large, biopsy of the omentum if normal, not complete omentectomy. Removal of the adherence or the abnormal omentum, and inspection of the contralateral ovary with biopsy of the only abnormal contralateral ovary. And also the fertility sparing surgery should be the only treatment in germ cell tumor. With a contralateral macroscopically normal ovary and negative imaging, biopsy is not. Sometimes we know that we do the contralateral ovarian tissue biopsy, but if it is normal looking, we do not do the biopsy of the opposite ovary. And in cases of the macroscopic bilateral ovarian tissue, that is what Professor Dr. Amita Madam, she told that there is preservation of at least part of one ovary, that is unilateral sulfing oophorectomy and contralateral partial oophorectomy, and the preservation of the uterus encouraged unless genetic analysis reveals the genetic owner. If an hysterectomy has been performed, and then there is and we shall wait for the final histopathology report, and when adjuvant medical treatment is necessary, in that cases we shall not go for the resurgery. If we think that there is the stage 1A tumor and that is only observation after final histopathology report, in that cases we can go for the staging laparotomy. If the diagnosis is come in the post-operative of comprehensive staging with lymphadenectomy is to be avoided. And the management in the advanced stage, here also the fertility surgery should be done, because germ cell tumor, it is highly chemosensitive and extensive cytoreduction surgery should be avoided. In case of macroscopic extraovarian disease, location, size, and clearly documented, and the extraovarian disease should be biopsied. And the adjuvant treatment in also in the advanced ovarian tumor, the completely resected 1A tumor, active surveillance is the preferred method. And in the case of the yolk sac tumor stage 1A, where the patient is non-compliant, adjuvant only maximum 2 cycles of chemotherapy, and in management of stage 1B neoplasm, that is, it is a rare cases, is complex and should be according to the histotype of the tumor in both ovaries. But stage 1C and the situation is equivocal. Both options, either may be chemotherapy or maybe active surveillance. But in stage 1, C2 and C3, the all types should be received the adjuvant chemotherapy, but it must be maximum 3 cycles of the chemotherapy. And now we shall go for our second case. Our second case.
1 second, Dr. Shana, can I ask a question to AK?
Yes.
Yeah, so my question is, do we give 2 cycles as per this guideline suggest only 2 cycles in stage 1A this thing and 1C also? What is the practice, AK, there? And
stage 1A in yolk sac tumor only in stage 1A, where the patient is non-compliant for the surveillance.
No, so there the recommendation now is to give, just show that slide of recommendation, only 2 cycles of chemotherapy, not 3.
I am saying, yes.
We still give 3.
Yeah, I sort of understand the concept. First of all, I will say, Amita, I agree with you. We usually give 3. And I would say that there really, I cannot think of a situation with a malignant germ cell tumor unless it's a very small dysgerminoma, or an immature teratoma grade 1, stage 1A, these very indolent, very good prognosis tumors. But something like a yolk sac tumor, I would say pretty much we would always give chemotherapy, and the standard would be 3 cycles. I see what Shahana is talking about here, which is if you follow the NCCN guidelines, they do say that there's a category of low risk that can be just observed. And that really is up to clinician, responsibility and decision-making about the risk factors. For sure, we do have this model in, say, GTN, where there are some women with GTN where in general we would just follow them, but we're worried we're going to lose them, and we would give prophylactic chemo. This is really the first I've heard of doing that in germ cells. So that's quite interesting. Thank you for bringing that up, Shahana.
Yeah, so I think in pediatrics especially, there are studies, intergroup studies, which have shown that, yolk sac tumors can be, but in adults, I think the risk of recurrence is slightly higher. And maybe, I don't know, we still practice 3 cycles, so not 2 cycles of chemotherapy.
Yeah.
Thank you. Thank you. Yeah.
Yeah, and just I know we have another case, but just to get back to the issue of this particular patient, the 16-year-old who recurred 7 months after very treatment. In fact, you could more chemo than she would need, and you worry about her. I put in the note, a paper from ASCO on management of refractory germ cell tumors. So in this group, you clearly worry about her, that this is a very worrisome situation to recur within 7 months. Different than your standard patient.
We have the medical oncologist, Dr. Monish Sharma. Sir, please, your opinion. Dr. Monish Sharma.
So I also practice giving 3 cycles of chemotherapy. So this is, I think, new for me. As rightly said by AK, it's very extremely rare to find 1A, 1B, 1C tumors. But if it is a 1C tumor, consider it as good risk, and we give 3 cycles. Anything more than 1C is intermediate and high risk, and we give 4 cycles of chemotherapy.
Can we go for the second case? Yeah. Mrs. 27 years, para 1, living on, attended in our gynae oncology OPD on 20th May 2021 with complaints of the distension of the abdomen for 3 months, nausea and weight loss for the same duration. On examination, there was 18 into 20 centimeter, partly solid, partly cystic mass with irregular surface and ill-defined margin occupying hypogastric both iliac and fossa and up to the umbilical region with restricted mobility, and the mass is impact up to the pulse of Douglas. Now, the poll questions: which is the preferred imaging method for diagnosis? The same questions like the germ cell tumor. In this cases, ultrasonography, whole abdomen, CT scan of the whole abdomen with contrast, MRI of the pelvis and abdomen, PET CT scan. As the patient is the tertiary care center, in that cases, what should we do? Yes. 12% is in favor of the ultrasound of whole abdomen. 57% participants are in favor of the CT scan of the whole abdomen with contrast, and 33% MRI of the pelvis, and nobody is in favor of the PET scan. Now, Dr. Farhana Kalam, what is your opinion in that cases?
Thank you, madam, and thanks the Oncology Club for giving me the opportunity. I think CT scan of whole abdomen with contrast is the preferred imaging method here.
Why? Why you will go for the CT scan? What is your...
Madam, I think CT scan is the primary imaging modality used to stage ovarian cancer, and it is sometimes complementary to surgical staging. And there are some relative criteria for non-optimally resectable disease has been developed, like lymph node enlargement above Lennar hilum, if there is porta-hepatis involvement, root of mesentery involved, liver parenchymal involvement, subcapsular involvement. In that case, these are the relative criteria for non-optimally resectable disease. And we can give this information from CT scan. That is why CT scan is the preferred imaging method here.
Abraham sir, what do you practice in your center?
Yeah, we are also using CT scan, but I suppose this point that was raised that in young women to reduce the amount of radiation, MRI may be better. So that point has to be considered.
The diagnostic performance, what is the guideline says? The diagnostic performance in detecting the ovarian cancer recurrence, that is the CT scan, it has sensitivity 79% and the specificity 84%, but MRI has the 75% and the specificity 78%. And also the role of CT scan, that it is the CT is the primary imaging modality used to the staging of the ovarian cancer, and it is complementary to surgical staging, identify the possible site of the unstaged disease, which include the pelvic peritoneum, paraotic, lymph nodes, diaphragmatic nodes, and cystole. And the relative criteria for non-optimality of the resectable disease have been developed. These include the lymph node enlargement above the renal hymen, parenchymal metastasis, peritoneal implants over more than the 2 centimeter along the diaphragmatic sac, and the porta-hepatis and the root of the small bowel, mesentery, etc. So we advised, she attended with the ultrasonography of the whole abdomen, this showing the 15 into 10 centimeter mass, the present in the pelvic cavity goes upwards up to the umbilical region, and there is moderate free fluid collection in the peritoneal cavity. And her tumor marker was C125 or more than 1000 international unit per ml, CA 2.86, CA 99 was 52, and their alpha fetoprotein and beta CG all were within normal limit. And other biochemical and hematological parameters of the blood are also within normal limit. We advised her for the CT scan of the whole abdomen with contrast. There is a large solid mass enhancing viscosity lesion having the solid and cystic component and internal separator are noted in both adnexum. Right one measuring about 13 into 12 centimeter and left one measuring about 10 into 7 centimeter. Uterus could not be separated from the mass, whereas the moderate ascites and bilateral might be moderate hydronephrosis. Now the poll questions. Do we go for the GI workup for this patient, is it mandatory for every cases of the bilateral ovarian tumor? Tanya, there are only two single answer, yes or no. Tanya? Yes, 68% the participants are in favor of the GI workup and 32 in every cases of the ovarian malignancy, and 32% are not in favor. Now, Dr. Farhana, will you go do the GI workup for these patients? What is your opinion?
Madam, in this case, the patient has bilateral ovarian involvement. So I want to do GI evaluation, as because it may be the metastasis from other side to the ovary, or maybe the mucinous ovarian tumor. In that case, there may be mimic GI cancer with mucinous ovarian tumor. So GI evaluation is indicated in this case.
Sir Abraham, sir, do you routinely do GI workup in ovarian malignancy?
No, I do not. Only if there are symptoms to suggest it, or if I think it might be like a mucinous tumor, or when the CEA is elevated, I would do it.
So
Otherwise, I
bilateral
don't.
if it is
No,
bilateral,
just because it's bilateral, I will not do. If the CEA is normal and there are no GI symptoms, I don't do.
Amita madam?
Yeah, so that's what our policy also. Symptoms and tumor markers only if there are GI symptoms or CEA or CA19-9 elevated, the ratio between CA125 CEA is altered, then only we do GI workup, because advanced serous cancers, we see bilateral involvement in at least in our series, it's more than 50% patient would have bilateral involvement. So we don't do it for every patient.
What is the guideline for the GIT evaluation? The same, that is the preoperative GIT evaluation should exclude the other primary cancers of the ovary, and the colonoscopy is indicated in any patient who have evidence of the frank or the occult blood in stool or a recent history of diarrhea or constipation. And upper GI endoscopy is indicated if there is the upper gastrointestinal symptoms such as nausea, vomiting, or hematemesis, and GI cancer and primary mucinous carcinoma of the ovary both causes the serum elevations of the and both presents with adnexal masses. GI tract evaluation is in these patients to determine whether the patients have metastasis to the ovary or the primary mucinous carcinoma of the ovary. And but we did the endoscopy of the upper GIT and colonoscopy and also chest X-ray, and both were the normal. And but now, what will be the next treatment plan for this patient? This is the poll questions for the participants. Now, this is a bilateral ovarian tumor with a huge mass with the ascites. Will you go for the primary cytoreductive surgery or NSCT followed by interval debarking surgery? What is your opinion? The poll question, Tanya, please. Tanya?
এই কোশ্চেনটা মনে হয় মিসিং গেছে পোলে।
Farhana, what will you do with these patients? Will you go for the primary debulking surgery or the NSCT followed by interval cytoreductive surgery?
Primary cytoreductive surgery with R0 resection is the preferred surgical method for advanced epithelial ovarian cancer, but sometimes primary cytoreductive
No.
surgery cannot be
No,
done
this case,
if
this case, what will you do here?
here the mass is huge and the patient is young, and there have some limitation in these cases. So NSCT with IDS can be done.
Okay, what will you do? What is your
Yeah.
preferred method?
Yeah,
This
so,
finding.
sure. So, first of all, I would say that there's a huge body of literature now that suggests that outcomes are probably equivalent with NACT followed by interval cytoreductive surgery versus upfront cytoreductive surgery. So clearly it becomes a clinical call based on how sick the patient is, the urgency of surgery, your identification based on your imaging, whether you think you can optimally cytoreduce, and patient comorbidities, right? All that stuff comes together. For this particular patient, I totally agree with Dr. Farhana. I would definitely recommend primary surgery. She has bilateral hydronephrosis. You are not going to fix that with upfront chemo. Your only other choice is to have a urologist see her and place stents if you think you cannot do a primary intervention. So that kind of, for me, in a patient with no comorbidities, the size of the masses per se do not lead me to think about whether this is cytoreductive or not. The issues about resectability mostly have to do with the porta hepatis and upper abdomen. In general, you can pretty much righteously cytoreduce the pelvis. It may require a rectosigmoid resection. It may require a colostomy.
This patient.
Yes. Yeah, this patient.
Yeah.
This patient, I would do primary surgery based on what I'm telling you. You know, like I say, the size of these lesions in and of themselves does not mean you can't do primary surgery. I'm not hearing anything about disease in her porta hepatis or her diaphragm or, you know, big bulky disease in the upper abdomen that you might not be able to cytoreduce. And the final thing is with the bilateral hydronephrosis, she's at high risk for renal failure, which means she will not be able to receive chemotherapy unless you do some intervention to protect her kidneys if you're not going to do surgery.
Yes, where there is we advise the patients here, when we will go for the primary cytoreductive surgery, the NSCT with interval debulking surgery should be considered in patients in advanced stage ovarian cancer who are not the good candidates for the upfront cytoreductive surgery, and due to advances, the frailty and the poor performance status, comorbidities, or who have disease unlikely to be optimally cytoreductive. And there is the study on the PDS and the interval cytoreductive surgery. There is the 2 published large prospective randomized control trials, the primary debulking and the interval debulking surgery. The EOTC studies and PORAS trial have been served as the foundation of these, the advanced stage, the approach, NSCT approach. Both concluded that NSCT with RDS was the possibility of then the PDS and yielded the comparable survival outcome and decreased the severity of the morbidity in the comparison with the PDS. A Scorpion trial and the Japan Clinical Oncology Group demonstrated that the rate of the perioperative complication for IDS than the PDS. And the American Cancer Society, the American Society of Clinical Oncology also recommended that NSCT for the patients with high perioperative risk or the low likelihood of the achieving the optimal debulking. And NCCN guideline also, they have the specific recommendation. And these patients, we have advised her for the primary cytoreductive surgery, but the patients and her attendant, they did not deny for the primary debulking surgery. They told that we shall go for the, please give us at first medicine and then we will go for the surgery. So we have decided her for giving the primary interval debulking surgery after NSC 3-cycle chemotherapy. And for that reason, we have, after biopsy report, we advise her the interval debulking surgery. And which method is for this, as we know, we need to know that the tissue status, the tissue performance, and which method is preferable for doing the giving the chemotherapy, either FNAC or core biopsy, the participant. What will you do if this type of patients will come to you with a huge abdominal mass where it is inoperable or the party denied for the primary developing surgery? Will you go for the FNAC biopsy in ovarian masses? So 88% are in favor of the core biopsy. Because the core biopsy, as the FNAC fails to reveal the tissue architecture necessary for the tumor typing, as maximum, sometimes we get the patients are coming with only the FNAC report. Where the facilities available, we must go for the core biopsy because tissue is the issue. And it is found to be the slightly less than the true-cut biopsy in adequacy, 81%, diagnosis accuracy 95%, and sensitivity 94.3%. The true-cut biopsy offers the high accuracy of the grading and the typing of the case of the pelvic tumor, and it is an efficient, minimally invasive, and accurate, safe diagnostic method. So, concluding, true-cut biopsy acts as an adjunct to cytology and histopathology for the reliable diagnosis of the pelvic of the ovarian tumor. And the CSN guideline also, they are in favor of the FNAP should be avoided for diagnosis of the ovarian tumor, but it may be done only core biopsy. It should be the ideal treatment, and where the core biopsy not possible, then FNAP may be necessary in patients with bulky disease who are not the candidate for the primary debulking surgery. So we advised that the core biopsy, and core biopsy report was the papillary serous adenocarcinoma. So Dr. Farhana, are you satisfied with this type of only report, that is papillary serous carcinoma? With this report, are you satisfied?
No, madam, I want to know more from the report.
Why?
Because here only mention about papillary serous cyst adenocarcinoma, but grade is not mentioned here, whether it is low grade or high grade.
Is the differentiation between low grade, whether it is low grade, what did you do, and high grade, what did you do?
High grade ovarian tumor are mostly chemosensitive, platinum and carboplatin and plaquetexer sensitive, and they have association with BRCA mutation. And we know low grade serous tumor are less responsive to chemotherapies. That is why I want to know the grade of the tumor.
What other information is tested? Whether we did go for the BRCA testing in these cases?
BRCA testing facilities is costly in our country, but if she can afford, we can advise her for BRCA testing.
When will you advise the BRCA testing? At the primary diagnosis or the after the end of the surgery? When will you advise the patient for BRCA testing?
At the time of diagnosis.
Amita madam, what do you do in your center for BRCA testing?
So we counsel every patient of epithelial cancer, non-mucinous type. We counsel them. We have a genetic clinic. So we refer them to genetic clinic, and patients who can afford, we test them for BRCA. So in this case, like on biopsy, if you got the report, we can test her for BRCA now or later also. So you also have to see patient's pocket, because if they have X amount of money, the frontline treatment anyway is not largely affected by BRCA status. So if patient doesn't have money for testing upfront, we may wait for her to complete the initial treatment. If patient can afford, we do testing along with the diagnosis.
The patient received 3 cycles of the chemotherapy with paclitaxel and the carboplatin up to the August 2021. And how is the patient after receiving cycle NSCT, whether this is suitable or it is the patients are the disease, or it is the partial response, or it is progressive disease? Farhana.
For assessing the patient after receiving 3 cycle of NSCT, first of all, we get a history from the patient and do some clinical investigations and then clinical examination and then some relevant investigations.
Yes. Then what is that? There is some criteria for the RECIST criteria for the treatment response, the showing the treatment response of the patients in case of the solid tumor, that is complete response, partial response, stable disease, and the progressive disease. We did the investigation profile after receiving 3-cycle chemotherapy and CT scan of the whole abdomen with contrast showing the multiple complex cystic mass in the abdomen, mid-abdomen and pelvic cavity adherent with the uterus, largest one measuring about 13 into 10 centimeter and into 10 centimeter, and there was also the small amount of the ascites. And the bilateral, still the bilateral hydronephrosis is persisting, gross in the left side and small in the right side. An investigation profile after this 3-cycle chemotherapy, the tumor marker C125 was before chemotherapy, it was 1000, now it is 1387 international unit per ml. Now, what type of response occurred here according to the RECIST criteria, Farhana?
This is, there is no response actually, so this is stable disease.
Our tumor marker is size of the tumor, but its tumor marker is
Size of the tumor was as it is, 30, same 13 into 12 centimeter, and tumor marker was CA125. Before NSCT was 1000, and after NSCT it was 1387. So the disease remains stable.
So we have done interval cytoreductive surgery, and in the 4th October 2021, and we did the complete cytoreduction as because the complete cytoreduction was done, and there was the less than around 1 centimeter tissue was left behind, and histopathology report is again pending. Then my question is, can we continue the same chemotherapy regime for this adjuvant chemotherapy for these patients? Monish sir, please.
So, have we get the chemotherapy? The cytopathology report? We have not still got the cytopathology report, right?
Yes, sir. Cytopathology, no cytopathology. It was core biopsy report. It was serous adenocarcinoma. Then she received pegcetacoplan 3-cycle, and there was a stable disease, and we did the surgery. And now, what will be her next adjuvant chemotherapy? The same pegcetacoplan, or we shall switch over the another chemo in this patient?
So I don't feel she had quite a good response to chemotherapy. CA 125 was the increasing trend, and the imaging just showed a stable disease, right? I would like to wait for the cytopathology report to look for the response to treatment. So if the final histopathology report shows some good response to the treatment, only in that case I would continue with paclitaxel and carboplatin, plus I would surely add bevacizumab in this case. If the final histopathology report shows no or minimal response to the treatment, probably we are dealing with some platinum-resistant kind of disease. In that case, I would surely change my treatment and add bevacizumab.
Abraham sir. Abraham sir, Amita madam.
Yeah, so I agree. I think it's very important to get histopathology report here. She's a young lady, 27, with no response to chemotherapy. So it's important to know if it's a low-grade tumor or is it a really high-grade kind of tumor. If it's a low-grade and if a complete cytoreduction has been done, and if it is, we do ERPR on low-grade tumors, and if it is ERPR positive, strongly positive, and if there is no disease left behind, we may just put her on hormonal treatment, letrozole or some anti-estrogenic therapy. But if it's a high-grade tumor, and if we consider it as no response to paclitaxel 3 cycles, then we switch over to second-line chemotherapy.
Can I just add
Yes.
something? Yeah.
Yes.
So getting back to my point, I think she should have had a primary reduction. The thing with these very large cystic tumors is they can be sanctuaries against chemotherapy. And I see this over and over again, where you have a response to ascites perhaps or other stuff, but you never really see the shrinkage of your primary therapy, your primary tumor with chemotherapy. To the other points brought up by Dr. Farhana, Dr. Amita, and everybody else, from an FNAC in a very large tumor, you potentially have a sampling error. And so you may not actually be treating the right thing. And for sure, this could be a low grade. But I don't think you can really say that she has chemorefractory disease, because with those very large masses, very commonly, you will not have good shrinkage in those masses. They're mostly fluid, or they're mostly mucin, or whatever they are. And so primary therapy to cytoreduce them is something to consider, plus you get very good histopathology. So that's something to consider. As far as continuing now with the chemotherapy or not, you absolutely have to wait till your pathology. You can't really consider the next steps until you have your histopathology. So, yeah.
Yeah, I agree with you, AK, about, in fact, I also, if you see CT scan, these are largely cystic masses and very solid areas relatively less. So these tumors do not respond in terms of size to chemotherapy. The other point I want to make, the first CA-125 more than 1,000, actually they should have, it's a good practice to have the exact value rather saying more than 1,000. So we really don't know. Second time we have the exact value, but first time it was just for more than 1,000. So we don't know CA-125 when there was actual elevation or it was high even then.
And then just one final point about chemotherapy sanctuaries. It's interesting because, we are in our, I call it our silo. This is our little world of gynecologic oncology, but actually it's interesting to cross-fertilize with oncology, colon cancer, and other particular subspecialties in oncology. The concept of chemotherapy sanctuaries is quite robust in these other specialties. And I've been consulted many times by GI oncology to go in and take out ovaries where there's ovarian tumors in a woman with metastatic colon cancer, where that's the one place there's no response to chemotherapy, and it's thought to be a sanctuary from the chemotherapy. Not that the chemotherapy is ineffective, but it just doesn't penetrate that particular tumor. So something to reflect upon in our own subspecialty.
So, AK, I have a question here. Yeah, we discussed many times that we should not be trusting the CA-125 as a predictor of response. Rather, we should go for imaging. But here we are dealing a different situation. So we need to take a decision that whether the gold standard Paclitaxel should continue or we are switching to something else. As you said, there is a valid reason to believe that even it is a wonderful drug for this sanctuary concept or the cystic issues, it is not really doing a great job, but it may so happen that after the surgery, same drug may do a good job, because in ovary, we should not exhaust all our weapon. Very sporadically moving one to another, because very short time we will exhaust everything. So do you think that Amita raised a very interesting important point that if we had an exact figure of CA-125 before, maybe for the chemotherapy, would it treat as a response or not here? Okay, I think you're not there. I don't know.
Yeah, no, I agree. Ultimately, I think it's no one thing, right? We are ultimately clinicians, and we use our clinical judgment, and our tools and our guides include blood work, x-rays, patient's performance status, physical examination, and all that together tells us what to do next. For sure, I think in some situations, the CA-125 can be an exquisitely sensitive marker of response and allow us to not have to get extra scans because it's so good at telling us how we're doing. That's not the situation for this patient. That's interesting. It worries me a little bit, but I don't know how much of that CA-125 is coming from this large tumor, in which case you got to get rid of that large tumor to see. I do think all those things, anything we can do to help guide us is important. We're flying blind so much. So I support using everything we can.
This is already discussed. Do you want to give any maintenance therapy? Because Dr. Monish, she has the advice for the bevacizumab if the patient can afford. And I think that we are at the end of these cases because we want to give some message again, like the germ cell tumor from the guideline for the gynae colleague.
So not all of my patients, they will go for maintenance treatment in high-grade serous ovarian cancer. So there are two concepts in maintenance. One is with bevacizumab and another is with bevacizumab plus olaparib. So if clearly we have not done the genetic testing for this patient, if we find if she has a genetic mutation such as BRCA, if it is available, then in that case probably the best choice would be to go for olaparib plus bevacizumab. And if she doesn't have a BRCA mutation, then bevacizumab maintenance is a question because as per ICON 7 and GOG 218, the addition of bevacizumab has just got the progression-free survival advantage, not OS advantage in all of the patients. A few of the patients who are not adequately cytoreduced or have gross ascites at presentation, they would be the patients who will receive bevacizumab. Otherwise, not all patients, they will receive bevacizumab because of overall survival benefit is not there in all the cases. If we give bevacizumab, we have to discuss with the patient the side effects, pros and cons, and to tell them that it is you're not going to live long with this. But it will help the disease not coming back again.
Okay, thank you very much, sir. Now we have some message for gynae colleague that the germ cell tumor, there's some diagnosis and preoperative workup like the routine ultrasound. In case of any adnexal cell masses, the primary workup tool is the ultrasound, then the advanced imaging like either and testing the mucinous or non-epithelial tumor and adnexal cell origin, and surgical management for stage 1 and 2 epithelial ovarian cancer. In that cases, we must have to go for the midline laparotomy, that the incision must be given midline. And apparently in stage 1 disease, the rupture of an intact primary tumor with the space of the tumor cells, they always be inhibited, and the extraction of the specimen should be avoided. And also the availability of the frozen section must be done. And where the frozen facilities are not available, the absence that the two-stage procedure should be done, and the laparoscopic restaging in an acceptable approach if the performance by the gynecologist, the adequate expertise to perform a comprehensive assessment, and when no suspicious lungs are found in the pelvis, paracolic areas, and the subdiaphragmatic areas, and blind peritoneal biopsies are recommended. At least infarcolic omentectomy should be recommended, and the bilateral pelvic and paraotic lymphadenectomy should be done up to the level of the renal vein. And in advanced stage cancer, stage 3 and 4, in that cases also, if we go for the upfront surgery, the midline laparotomy is required, and the complete restrictive management and voluntary use of the incomplete surgery, that is upfront or the interval, is discouraged. And the criteria against the abdominal debulking are diffuse infiltration at root of the bowel mesentery, carcinomatosis, and also diffuse involvement of the deep infiltration of the stomach, duodenum, head of the middle part of the pancreas, involvement of the truncus arteriosus, and also metastatic stage 4 disease may be resectable, but central or the multisegmental parenchymal liver metastasis, typical parenchymal lung metastasis, and non-resectable the lung metastasis and multiple brain metastasis are not, and risk-benefit ratio must be given, and there is no unresectable tumor extent, and the complete demarking to no residual tumor seems feasible with reasonable morbidity taking into account in patient's status. Decisions are individualized and based on the multiple parameters, that is patient accept potential supportive measure as blood transfusion, and interval working surgery should be proposed to patients. They fit for the surgery response and the stable disease compatible with the complete resection. If a patient did not have the opportunity, a patient who progressed during NSCT should not be done, and unless for the palliative reason that cannot be managed conservatively, and careful the review of the pathology report, which is very important, as we have seen that is possible low grade, and the additional work in mucinous adenocarcinoma that is possible GI secondary should be evaluated in these circumstances. And the minimum required information should be reported, that is after the surgery report, the all necessary information about sites of the disease and the size of the disease, the tumor status, dissemination pattern, resection performed, and the residual available in the operation protocol, and the tumor dissemination pattern with the site and the site of the tumor lesion described at the beginning of the operation protocol, and the all areas of the abdomen and the pelvic cavity should be evaluated, and the all the completed surgical procedures mentioned, if any, the size and location of the residual should be discrete. The result should contain all the necessary information. Now, we are going to schedule the presentation in a new method and different way, because the our president sir, his comment is because the participants, they must have to join. So we have given these 4 questions, and accordingly in between, so anybody can participate for this presentation. So we have the did in a different way, and I think we shall continue with thanks to all the faculties. Now I request our scientific secretary, Dr. A.F.M. Kamaluddin Bhai, for your recommendation for this presentation.
Thank you, Shahana. This was a good interactive session. I think gradually we will have much better discussion. As you said that as per the advice of our president, we are trying to engage more our participants in the total process. So we are bringing these 4 questions and the discussions. And hopefully our local faculties will be bringing up more issues so that we can have more interesting discussion with our foreign faculties. And as usual, I mean, now we are so happy to have all the foreign faculties support continuously, like Dr. Abraham from such a long area in Oman, he is joining. And after a busy day, busy week, Amita is sparing her holiday, and AK has been supporting us, and also our medical oncologist from Rajiv Gandhi. Thanks to all of them. And hopefully with this support, we can continue this effort, and this effort of bringing the practice of evidence-based medicine in our oncology field will continue, and hopefully we will give improving the cancer care in our region. Thank you very much.
Thank you, Dr. Kamaluddin and Dr. Shahana.
Thank you.
Thank you. Good night.
Right. Okay, please wait 5
Yes,
minutes.
it was very well done, this interactive session. Thank you.
Thank you, sir. Thank you very much.
What's your time, Dr. Abraham? You look so fresh.
No. Yeah, I'm 2 hours behind. 2 hours behind the Bangladesh time. So
Yeah,
Okay.
it's 12:30. Sir,
Yes,
your
it's 8:30 here.
okay.
Okay, 8:30. Dinner time.
Anna, probably Dr. Latifa Shamsi to join today.
So we can ask our foreign faculties also if they have some suggestions to make some more modification in this design to make it more effective. You are always welcome to.
Okay. Right.
Sir, Latifa appa join করছে স্যার?
Islam দেখছিলাম তো।
আচ্ছা আচ্ছা। শাহানা দেখো।
Okay, I'll take your leave now.
Sir,
Thank you very much.
Sir, have
Yes,
you any suggestion or Amrita madam? Have you any suggestion?
No, I
Or-
think maybe good idea to ask local people a suggestion on the format, and also you mentioned about the day, many conferences and also that you can check with local people.
You know, I mean, one suggestion I might have would be to, in advance of your topic, email or WhatsApp out a good review article for people who have the time. Not everyone's going to have the time to do this, but if they have the time to read it, they will come with some background information. It makes it a little bit more scholarly and may generate some questions, especially among the younger learners. So just as a thought.
Okay, thank you.
Thank you. It's a good suggestion.
Thank you. Now I request our presidents to tell something and conclude the session, but Tanya, before that, they show the poll winner last week's. Sir, please. Dr. Farhana Kalam, Shujarana Tabassum, Yes Rahman, who is this Rahman? I don't know. Yes Rahman, Shujarana Tabassum, I don't know. Farhana Kalam is our 2 days faculty. Okay, thank you. Sir, please conclude the session.
Okay, thank you, Dr. Sana. I'd like to thank all the faculties and participants. We had a very nice discussion today, good interactions. I think we should have to continue these things and also try to change our format as Dr. Aki has advised today. Zana, please take care of that. And thanks to everybody else once again, and a goodbye. Allah Hafiz.
Salam.